We are back on Morning Line. Thanks for joining us this morning, talking about babies born dependent on opioids. Yes, an uptick in this as we see an uptick in opioid addiction among all Americans. It is a huge crisis. It's also a huge cost beyond just the health cost and what it means to the individuals involved. With us this morning is Dr. Stephen Patrick. He's over from Vanderbilt University, pediatrician, a professor there as well, a neonatologist. Nice to have you on. Thanks. You're really good at explaining this stuff. You know, as we went to the break, you were talking about just the average length of stay for a healthy child. It's born maybe 2 days tops, maybe sooner than that. A child born addicted to opioids or something else that's an illicit drug could be up to 3 weeks plus.
That's right.
So the cost on a national scale, we're talking billions of dollars.
Yeah, so we know that in 2012 is about $1.5 billion in hospital charges. That's the total national hospital bill for just this one problem and just during the hospital stay.
Just during the hospital stay. And you see an uptick. We see more cases? Because I would imagine with what we see in opioids in this country, we're seeing more and more.
That's right. And so we have not seen a decrease. If you look at the state numbers from Tennessee, they've plateaued a bit, but nationally we've continued to see an uptick. And we know that if we look kind of where it's grown over the last period of time, Tennessee has a rate that's about 3 times the national average compared to the rest of the United States. And really the growth of neonatal abstinence syndrome or drug withdrawal in babies has been in rural settings over the last 10 or 15 years.
Why do you think that is?
Well, it mirrors overdose deaths pretty accurately, and we're beginning, as we look at the opioid epidemic more broadly, Appalachia is really disproportionately impacted. So states where I was born, West Virginia, throughout Kentucky and Tennessee and the western part of North Carolina, is really impacted by overdose deaths and neonatal abstinence syndrome. You know, one of the things that we're learning as more economists are looking at this, they have a term called deaths of despair, where there's lack of opportunities, lack of jobs, things like that. We're seeing an increase in drug use and opioid use.
Makes sense. Makes sense. You see that in a lot of the counties here in Tennessee that are really struggling, especially the rural ones. And it's big in methamphetamine over in those areas as well. That's a very easy drug to make, unfortunately. Let's go to Grady. Grady, good morning.
Good morning, Nicholas and Dr. Stephen. Happy birthday.
Oh, thank you.
I remember when I was old enough to vote and drink at the same time. But, you know, I mean, I've always tried to stay away from anything other than aspirin. But, you know, nowadays with all the side effects, they're talking about medications. Where's the Drug Association coming out with this medication that can be so addictive? And I'll hang up with y'all's comment.
Thank you for that. You know, again, you see the front lines of it, and again, not to be political, but as a doctor, you see the pharmaceuticals. And I think a lot of people would say the pharmaceutical companies that make some of these pain pills are largely responsible for making them so readily available and churning them out the way they do. What contact do you have with them, and what observations do you make just from what you see day in, day out?
Well, what we know, if we look nationwide, we've seen a 4-fold increase in prescriptions for opioid pain relievers.
Someone's getting really rich.
So
lots of people.
Yeah, that's right. And even though we've seen a recent decrease in overall prescribing in 2015 was still 3 times what it was in 1999.
Is that right?
And if we look at, so the Surgeon General last year took this issue on, and what he said was that the road that we find ourselves on was paved with good intentions. It started with thinking about how do we take care of untreated pain and things like that. But what happened was there was a lot of misinformation about these drugs and their risk of addiction potential. There's an article, a small article in 1980 in the New England Journal of Medicine. It was just a few paragraphs. And from that, they basically found that they had a statement. Again, it was like this long that said the risk of addiction for opioids is small among people that are treated for pain. We found that not to be true. And we also found that there was a lot of marketing of these medications aggressively and without data. And a few years ago, there was a $600 million fine to one of the manufacturers, Purdue Pharma, for the way that they marketed these medications. And so we're seeing now a reaction to this problem as we go forward. But I think it should give us some pause, and we should remember where we are. And now we're catching up. We're catching up as we see the complexity of the opioid epidemic change. We're seeing a somewhat decrease in leveling off of deaths for opioid pain relievers, but we've seen a big increase in deaths from heroin and fentanyl.
Yeah, I was going to say, I'm glad you brought up fentanyl.
Yeah.
And is fentanyl, it's an opioid, right? Or is it a, it's added to some of these drugs, and it's very powerful. But what is it?
It's a synthetic opioid.
Okay, yeah,
and
right.
so when I first heard about fentanyl being in street drugs a few years ago, it caught me off guard. Fentanyl is a medication I use in the as a drip to take care of babies after they've had a painful surgery or something like that. What's happened over time is it's illegally produced fentanyl, mostly coming from China, that is being added to heroin. So what we've seen is as we've been more focused on decreasing opioid pain relievers, the supply has gone down, and so the price has gone up on the street. Cheaper heroin has come in. It's around $65,000 for a kilo of heroin. But if you cut that with much cheaper fentanyl, that's about $3,000 a kilo. Fentanyl is much more powerful, much more likely to cause death, and it's essentially drug dealers making more money to do these things. And in Tennessee, some of the things we've seen too are things like medicines being shaped, pills being shaped to look like Xanax or Percocet, and it's actually pure fentanyl.
Yeah.
And that's why we're seeing such a big spike in deaths.
Well, and that's it, because if they don't know there's fentanyl in there, they take the amount that they think they were taking for one of those drugs you just said. And fentanyl's so much more powerful, and you have these overdoses. We see that just constantly happening right now. Can you talk a little bit about the physiology, I guess, or however, what is it again, not just in infants, but I guess in the mothers and the adults? Opioid goes to what part of your brain? Where does that addiction center get triggered by this drug? How does it work? Now, and we understand, by the way, have you ever taken an opioid for an injury? I had torn rib cartilage, and I took one once, and of course, I was terrified of taking the pill. But I took one, and I didn't notice a big deal. I certainly didn't feel some big high. I was thinking, why do people take this crap? And it maybe dulled the ache a bit, and then I stopped and then didn't use the rest of it. But I'm just wondering, what does opioid do? These opioids, in terms of pain, and where does it attack the brain and cause an addiction?
It's dopamine. So dopamine is kind of it's a pleasure response. So if you eat a meal that you really like, you get this response, and it makes you so that you don't starve and you go back to eat.
I like it, yeah.
You think about an opioid for someone who has dependency, that dopamine goes way up. It's a big spike in dopamine, and so it makes you to want to come back. It changes the way that your brain responds.
But it's odd. It's not like something where you hear about some drugs that I think, I mean, at least in my experience using it when I had injuries, where I thought, oh wow, this feels so great. You know, it's not that. I don't feel anything really. I mean, I guess it maybe mellows you, but it can do something to your brain where all of a sudden you just want it. But I don't get this like incredible feeling. And I am taking the recommended dosage. But what is it? I mean, are these people getting an incredible buzz out of this? I mean, I know if I drink a couple glasses of wine, I'm going to feel a little tipsy or something. I can feel that. Whereas if I take an oxycodone for my torn rib cartilage, I mean, maybe dulls the pain a bit here, but I don't feel anything up here. Now, maybe that's just me, of course. I don't know. If I took 3 of them, maybe I would.
Well, and we know that there is something about your genes, something about that you're wired. We're learning more and more that may predispose you to addiction.
Okay, yeah,
and so that's definitely true. I think as we're learning, different people respond differently, but even prolonged routine use, let's say that we prescribe an opioid for a period of time, people using it even as recommended can become dependent, and so it's good for short-term use. So if there's, it was really designed for acute pain and cancer pain, but long-term use may not be beneficial. It's one of the things where you should really talk to your doctor about.
Yeah, you have to monitor that closely. You know, the question of addiction, then I'm wondering, look, you have an infant that's born with this. You go through the withdrawal, the treatment. The infant hopefully does fine and then grows as, teenager and beyond. Do they always have to be aware of for the rest of their lives that they were at one time addicted to this opioid, and as an addict, which was what they were, not their fault, they have to be careful about ever coming into contact with that drug again?
There's not good evidence for that. And in part, when we think about babies, we call them that they're dependent upon medication. So they're born physically dependent, but they're not addicted because they don't have some of the psychological behavior where they go through and try to obtain the medicine after they're born.
But years later, if they popped one, wouldn't they all of a sudden, somehow on some deep subliminal level, it kick in and say, we've had this before and we like it? And maybe, I'm just wondering, I'd want to know if I was addicted to it, because I'd be more cautious maybe as an adult if I needed to go in for surgery and knew I was going to get these pain pills. I'd want to tell the doctor, hey, look, I was an opioid baby. Does that change anything? Because with adults it does. An adult who was addicted to that, that's the last thing they need to get again, right?
Well, again, there isn't great evidence for. I mean, you're worried that there may be some brain rewiring. Again, we don't know.
We don't know.
There's a lot of data that we don't know.
Okay.
That's an area that we need more research. But again, treating pain appropriately later on is probably still fine with the evidence that we have today.
The scary part of this too, as you said, it's rare because of the great work you guys do, but have you seen babies die from this when they're born with it?
No, I have not. And
okay,
so
great.
in part because we identify them in the hospital, one of the things I always worry about, if we don't identify a baby at the time of birth, that baby may go home and have drug withdrawal. And so I have colleagues at other hospitals who have seen some bad outcomes for babies that go home and have withdrawal at home.
Because the symptoms then would be what you were telling me, dehydration, they're not eating, they could have seizures.
Yeah, that's right. And so they can get very sick at home. This is a very treatable condition in the hospital, at home, particularly early. I mean, I've seen babies lose, it's common for babies to lose a little bit of their birth weight. They have a lot of, babies are born with a lot of water, right?
Right.
But I've seen babies lose more than 10% of their body weight within the first 48 hours of life. This is something that needs to be monitored in the hospital, and that's why we need policies to help screen and an environment to where people can be forthcoming about their substance use.
Okay, so you're doing that. What more needs to be done then right now? I mean, as you guys, I'm sure Vanderbilt's doing all that can right now, but where are we going on this, especially as we see the upticks and the spikes in the number of overdoses and the usage of this nationwide?
Well, one of the things is we need to continue to bolster some of the prevention strategies we have. So Tennessee has a prescription drug monitoring program. These are programs where if I fill a prescription for an opioid pain reliever, I go at the pharmacy, it monitors it in a database, and people can detect high-risk prescribing behavior. So if I'm a doctor that writes a ton of opioids, the state can detect that, and patient behavior too. If they're doing something high risk, like going from doctor to doctor to doctor, that's important. We need to continue to support those programs. Missouri just became the 50th state to have a prescription drug monitoring program. We need to continue some of those prevention, including take-back programs, things like that. But we need an expansion of treatment. Okay. So expansion of treatment, particularly where we have access to medication-assisted treatment, drugs like buprenorphine and methadone. There's just not enough access. As we've seen the opioid epidemic grow throughout the U.S. and in fact affect more and more people, it's really stretched many resources, particularly in rural areas. And so we need to see an increase in treatment.
Well, we'll talk once more about this when we come back from the break. But it's like, yeah, you can go after the users, but really, when you have that thing where you gauge the prescriptions and you find the doctors who are writing a bunch of those, you got to go after them. Okay, go after the doctors that are willy-nilly writing these prescriptions at these pain clinics, whatever. I don't want to hear about pain clinics, all right? And are making a fortune in writing for whatever, and making all this money at the expense of all of us, not just the users. We'll take a break. Be back with our final segment right after this.